Dr. Patel is proud to serve as the Maternal Medicine Director for the Macon Regional Perinatal Center. She is also an assistant professor at Mercer University School of Medicine and is passionate about resident education. She currently lives in Macon with her husband Byron and 2 children, Isaac and Isla. Please join me in welcoming Dr. Patel.
Hey, thank y'all so much for having me today. My name is Misti Patel, and like she said, I'm a maternal fetal medicine physician. I'm the doctor who tells you got to get induced at 36 weeks because of your blood pressure. What a hard act to follow. That was beautiful, Miss Pat, and I really enjoyed it. And I think one thing that Miss Pat brought up that is a privilege that I don't take for granted, especially when we're looking at numbers and statistics, is being on. It's such a privilege to me to get to participate in these bigger conversations about what's being done on a macro scale and what we should be looking at in terms of bigger picture things, because in my day-to-day practice, I get the privilege of looking at things on a very micro level, looking patients face to face and trying to optimize individual outcomes. And, similar to you, Ms. Pat, when I look at these statistics, there are names that come to mind. There are faces that I can still see. And so, I don't take the privilege of being able to be involved kind of on both sides of that spectrum, lightly at all. So thank you guys for having me here. I'm going to talk a little bit today about kind of what maternal fetal medicine is, kind of how can you wrap up what I do in a sentence or two to describe it. And then I want to talk a little bit about kind of some of the state initiatives that we do through our Macon Regional Perinatal Center, and kind of the idea of regionalization of perinatal care in Georgia and how we're using that to address some of the barriers to access to care, particularly as we're looking at causes of maternal morbidity and mortality and even going into the postpartum period. I have no disclosures. Some of the objectives for today are to talk about what maternal fetal medicine is, discuss the structure and function of Georgia's regional perinatal centers, understand the Georgia Perinatal Quality Collaborative and its goals, and then briefly review some of the Georgia Perinatal Quality Collaboratives that we're working on now, and then kind of briefly talk about what some of the needs of our state are going forward. And I know that there's been a lot to address a lot of these things today. So maternal fetal medicine is a specialty that I didn't know existed until probably my 3rd or 4th year of medical school. When I'm talking to patients, I say, kind of, if I could sum up what the goal of a maternal fetal medicine physician is, it is to, in every pregnancy that we see, minimize the risks of prematurity to the fetus and the neonate, while also trying to keep mom and baby safe and minimize the risk of things like maternal morbidity and minimize the risk of even, really scary things like stillbirth for the pregnancy. We deal in maternal medical complications, so moms may come see me if they have chronic medical conditions. Probably the most common that we see are hypertension or diabetes. I also deal a lot with moms who enter pregnancy with autoimmune disorders or maybe some rarer genetic syndromes that could affect a baby. Pregnancy-associated conditions, I know there's been a lot of talk about hypertensive disorders that are specifically related to pregnancy, or preeclampsia, things like that, preterm labor. We also see patients if there may be fetal complications. So if there's a fetal birth defect, if the fetus is thought to be at risk for any number of genetic conditions, even outside of kind of the normal ones that we screen for. And then babies who have growth disorders, so babies who may in utero be measuring too big or too small, particularly if that's associated with maternal medical complications. A lot of what I do is ultrasound, so we do screening ultrasounds to look at fetal growth and to look for fetal birth defects. In my office, I do consultations regarding both fetal complications and maternal medical complications. We also offer in our office preconception counseling, which can be important. I wish more moms made it to us for preconception counseling, because I think we as a field have a lot of work to do in helping women understand the medical conditions that exist outside of pregnancy and how those may interplay and interact with a pregnancy, and specifically what that may put them at risk for. I think particularly in my field, we take for granted things like every person can make the connection between what you're eating and what your blood sugars are, which I think often we take for granted. And so to be able to intervene in the preconception time period is always something that's encouraging and reassuring. We also offer inpatient hospital services. So we have a whole antepartum service, a whole antepartum floor of the hospital of moms whose pregnancies are so complicated that we say that they need to be admitted to the hospital long term. We run a clinic through the hospital with our residents where we specialize in the prenatal care of high-risk obstetric patients. We do that clinic every Monday, and people come from kind of all over the region, and I'll show a map of what our kind of encatchment region is in a little bit. But the way the volume has increased, I started my job here in 2019, and the increase in volume that we've seen since just I've started my job here in that clinic has been kind of astounding. So we see probably between 60 and 70 high-risk obstetric patients on any given Monday who come from a wide area to seek care. We also offer, procedures. We help with complicated deliveries. We can do amniocentesis or chorionic villus sampling to do genetic assessments, cerclage for cervical insufficiency. We can also do intrauterine blood transfusions for babies who are thought maybe anemic, and then procedures called exit procedures for babies who may have difficult airways. So it's really neat to be able to offer these kind of things in a place like Macon. And again, our prior concern is how do we help women access the things that we can offer. So in recognizing our kind of statistics and our position within our country as a whole with maternal care and maternal morbidity and mortality, in the idea for the initiation of the regionalization of care first came about in the 1990s. So the idea itself is probably about 30 years old now. However, it was just something that was kind of tossed around and not really kind of an organized thing or something that existed within, true guidelines or boundaries until about 2012, when both a maternal and a neonatal representative from each of the 6 proposed regional perinatal centers kind of got together. Mitch Rodriguez, who's one of our neonatologists from here, was actually really instrumental in building the guidelines for regionalization of care. And so it's been a privilege to get to work with him as he's still practicing now. But in 2012, really core requirements for regional perinatal centers and guidelines for how they should function, what they should offer, were really put into place and are still in practice today. And Macon is fortunate enough to be one of those regional perinatal centers. So this is what you guys have talked about ad nauseum today. I won't spend a long time on this, but access to care in Georgia we know is a big issue. So about half of our counties don't have any access to maternity care. Medicaid expansion has been a big thing. Policy changes that have affected our ability to kind of offer full scope obstetric and gynecologic care. And I'm so glad you brought up Sister Song, because they've also, that organization has also been instrumental in kind of working with some of the policy changes that we've seen, and then social and racial disparities as well. So the regional perinatal centers are a collaborative system of hospitals and providers that strive to assure that deliveries happen in the hospital with the appropriate level of care for the condition of the mother and the fetus. We offer comprehensive perinatal care for pregnant women, fetuses, and infants, medical consultation, assistance with the transports and transfers of high-risk mothers and infants for some of our more rural hospitals who could benefit from the services that we offer here. And then we also have, there's a big focus on outreach education to providers and staff at hospitals that are within the region who are not the actual regional perinatal center. So we have 6 in Georgia: Albany, Columbus, Atlanta, Macon, Augusta, and Savannah. And then here's kind of a map of where the catchment areas fall. And you can see our region is in the red, Macon is in the red. We serve about 29 counties surrounding Bibb County, or surrounding the medical center. So we get transports from all of those hospitals. We have a maternal outreach coordinator whose job it is to go into the hospitals of our region and teach classes on neonatal resuscitation, CPR, how to treat a hemorrhage, how to treat preeclampsia. She goes into emergency rooms, even in hospitals who don't have a labor and delivery or don't offer obstetric services, in an effort to educate for warning signs to look out for and possibly reasons that you need to be contacting, a more advanced center. When we're talking about, so the regional perinatal centers are funded by the Department of Public Health, who allots about every year, probably somewhere between $15 to $17 million to be divided up between the 6 regional perinatal centers. Those funds are divided up based on number of birthing hospitals in each region. They also take into account the number of non-birthing hospitals in each region, as it's also our job to serve those hospitals. Volume in terms of delivery numbers, how many transports we take from our surrounding counties. From the neonatal side, they look at things like, they divide it even into birth weights. So how many very low birth weight babies do we take care of a year? And that's kind of how they, there's a very specific algorithm that they use for allotting funds. Of particular interest to our region, we, in the last year, have had 4 birthing hospitals in our region stop delivering and stop taking care of obstetric patients. And I think that's pretty on par with a lot of the other regions too. And so I know that's something that y'all have talked a lot about, but something that, needs to be addressed on a bigger level. So to be a regional perinatal center, this is kind of the guidelines for what the Department of Public Health says that we should offer. So prenatally, we offer prenatal care, again, through our high-risk obstetric clinic, genetic counseling, educational services that range from, dietary classes, birthing classes, coaching on labor, parenting classes, lactation classes, social services. We are very fortunate to have a full-time social worker who is present in our high-risk clinic. And so you can help with very real issues that our patients have, like, transportation. Some of my clinics don't allow children to come, but I'm the only one taking care of my children. So, helping to bridge those gaps. It's like, I tell our residents all the time, I think, we can't forget, I think, that the vast majority of our patients, they want to do what we're asking them to do. They want desperately to come to all their appointments, to come to all their ultrasounds. But, there are things that if we don't ask, we won't know. Like, can you not come because you can't miss work anymore, or you won't have enough money to pay your bills? Those are things that, when we're talking about access to care, we have to really address on a patient-by-patient basis. And so we have a wonderful social worker who helps us as best she can with issues like that. We also do WIC referral. We offer diagnostic laboratory services and then antepartum fetal assessment. So, anatomy ultrasounds. There's antenatal testing that we do usually in the 3rd trimester if a pregnancy is complicated, to try to predict and prevent stillbirths, and then to monitor mom's health more closely too. Services that are offered intrapartum and postpartum. So there has to be, from a physician staffing standpoint, to be a regional perinatal center, there has to be an experienced obstetrician who's available 24 hours a day. And then that obstetrician also must have 24-hour access to a maternal fetal medicine physician who can help with the more complicated patients that come in. There are certain nursing staffing ratios that need to be met. The labor and delivery unit has to always be staffed with an anesthesiologist. Again, we have to have social workers. There are certain actual physical facility requirements that we have to meet in terms of what our OR room should look like, what our labor and delivery room should look like. We have to be staffed with lactation consultants, certified lactation consultants. And the ratios for that, they get very specific in that for every so many postpartum rooms that you have, you should have one lactation consultant to meet the needs of those. Again, we have both a maternal and a neonatal outreach coordinator who goes into our smaller hospitals and teaches educational classes. And then we have a data coordinator to collect data regarding outcomes at all of the associated hospitals. And then we have to be able to offer multidisciplinary care. So what consultative services are available at the hospital? Do we have cardiology? Do we have general surgeons if we need them? What's available on the neonatal side? Are there pediatric surgeons? Things like that all have to be taken into account. So the Department of Public Health has also initiated and worked with something called the Georgia Perinatal Quality Collaborative. And it is a more, so the goal of the Georgia Perinatal Quality Collaborative is to reach out to any hospital in Georgia who wants to be involved. So you don't have to be a regional perinatal center to be involved. We have very, smaller hospitals who don't do as many deliveries who are also involved. But the goal is really to reach out to all the hospitals in Georgia and give them, they call them bundles. So, evidence-based, ACOG, American College of Obstetrics and Gynecology-based guidelines to treat and handle some of the most common causes of maternal morbidity and mortality. So working on a very practical level to say, this should already be in place in your hospital so that when an emergency occurs, the steps are very defined and they're very uniform and they're very evidence-based. I am super sure you guys have probably looked at this today. So this was generated by the Georgia Maternal Morbidity and Mortality Review Committee, looking at some of the most common, some of the leading causes of death for moms in Georgia. Again, hemorrhage is a big one. Mental health conditions, I think, we're really only touching the tip of the iceberg into how mental health conditions and then, chronic stress and psychosocial trauma can affect outcomes for our pregnant patients. And so I think, we haven't done a lot of work with this from a state standpoint yet because I think it's going to be a really big job, but one that I'm really looking forward to because I think what we know about it is really just the tip of the iceberg. The big one that we're working on now are cardiovascular causes of maternal death. So cardiomyopathy, cardiovascular and coronary conditions, and then embolism and preeclampsia. So far, the GAP-QC has rolled out 3 bundles to address some of these causes. So the first one was our obstetric hemorrhage bundle. We initiated that in 2019 when I first started here. That bundle included things like making sure that we're doing a quantitative assessment of a patient's blood loss at the time of delivery instead of a qualitative assessment, because we know that as physicians we can underestimate the amount of hemorrhage during a delivery. And so being able to quantify it more accurately and then putting in parameters for when we may need to transfuse a patient to try to keep them from needing to go to the ICU or needing additional transfusions. Also helpful in this bundle was the initiation of keeping a dedicated hemorrhage cart on each labor and delivery that had medications that you may need in an obstetric emergency, and really having kind of a really practical checklist for labor and delivery units to use. The next one was the bundle for the treatment of severe hypertension in pregnancy. Kind of as Ms. Pat was talking about, we know that a lot of our complications are related to preeclampsia, even in the postpartum period. And so developing a really standardized evidence-based treatment protocols when we identify a patient who does have severe hypertension, so that there's not a delay kind of in treating that hypertension, which we know can put a patient at risk for seizure, stroke, death, things like that. The one that we're working on now is also has become a really big, it's a lot of work, but it's going to be one of the best things I think that we've done for our moms. So we're working on the cardiac conditions and obstetric care bundle now. I think that's going to be really important. And the cardiac conditions one does include a lot of kind of postpartum visits with patients and a lot of postpartum screening, which I think is going to be great. So this is what one of the bundles looks like. So this is an excerpt from the cardiac one. So there are different phases. So first, you have to look at a site's readiness. This talks about what does your unit physically have in place. Do you have talking about like addressing what's going on in the emergency department? Are there urgent cares that need to be involved and need to be educated? Kind of what is the physical setup of the unit? What screening tools are we using? What screening tools should we be using? What's validated during pregnancy? Is there a multidisciplinary care team in place? So this is kind of the step that we are at now, developing our multidisciplinary care team. We had our first meeting with cardiology last week, and it was very, very encouraging in terms of their interest in this issue and their willingness to be involved and to help with our patients. And then what additional resources might we need? So that's all part of kind of the readiness part of the bundle. The recognition element has to do with actually implementing the screening. What should your screening tools include? A really important piece of it, and I think is where the true collaboration of it comes into play, is it's wonderful to screen people for things, but what are you going to do when somebody screens positive? Like, that's really where the meat of the work comes in, is I've got a patient who screens positive for being at a high risk of a cardiac event, either during pregnancy or in the postpartum. So what do we do next? Which is where really the collaboration, especially with cardiology, anesthesiology, the ER, those kind of things comes in. And then after that piece is the response element. Again, what I was saying. So what are you going to do when you get a positive screen? What education pieces should be put into place? What should we be telling our moms before we discharge them home? So that they know when to come back, so that they know who to call if they have questions, so they know, what to look out for. With my preeclamptics, before they go home, I say, if you just feel funny, you call us, because, I have moms a lot of the time who say, well, I didn't know what was going on, but I knew I didn't feel right. And so, things like that. What do we need to be educating them about at all times? So before pregnancy, during pregnancy, and in the postpartum period. And then the reporting element, this is kind of the phase that we're in with the previous two bundles that we initiated. I wish I had data to share to look at outcomes from those, but I think that's all kind of, because it's all kind of new, that's all in the works. So hopefully in the next couple of years, maybe I can come and share some data about how these initiatives have kind of played out specifically in our hospital. And then kind of overarching to all of that is the respectful care element. So making sure we're treating our patients in a way that's fair and equitable and respectful to each individual patient's situation. We will, as part of the cardiac bundle, something that I'm really proud of, the plan is to implement the screening aspect of it starting on July 1st. So as of July 1st of this year, we're going to start on the inpatient side with the eventuality to move into the outpatient side. But every patient who gets admitted to either my antepartum service in addition, every patient who delivers a baby on the resident obstetric service is going to be screened for whether they're at risk of a cardiac complication either during pregnancy or after pregnancy. If those patients screen positive, the plan is that there are some labs that we will order, so every patient will get a BNP and an EKG, and then those patients will be seen by a cardiologist, and to make sure that they have appropriate both inpatient care and that they have really close follow-up from the outpatient setting. And so I'm so excited about that. I know it's just a drop in the bucket, but I think progress in itself, especially when we're talking about moms and their families and their lives, is a really good thing. So I'm really excited about that piece of it, and that's kind of where we are with this bundle. So with all we've done with the regionalization of perinatal care, I think it's great that the progress that we've made, but I want to fully acknowledge that it's not been all we need. It's great, but it's not all encompassing or totally adequate, because there are still women who we're not reaching, and I do think we can do a better job with education and with helping patients from especially a whole patient, caring for the social situation and the mental health situation. So I still think there are great strides to be taken. I think our cardiac bundle is a really great next step. I think in terms of the regionalization of care, what I would like to see the shift be is that I think we've always looked at our regional perinatal centers as somewhere that people should come to. And I want for that mindset to kind of shift into what can we be doing as a regional perinatal center to go out and go forward and meet people where they are. I do think doulas are a great way to bridge that gap, and definitely something that's being discussed. And so that's kind of a mind shift that I would like to see us take. I think that's kind of, and then the last thing I want to say to kind of end the day with is these are my two little ones. And now I'm going to get emotional. Complications are what I do. And I had two uneventful, beautiful pregnancies. I hid them under a white coat the whole time I was pregnant. But they were boring, and it was beautiful. And it occurs to me when I look at my children, and then it also occurs to me when I look at my patient, that I didn't want or deserve that any more than any woman I ever see. And so my goal with my job, and I think I want all of our goal to kind of be like, that's what every woman deserves. And I think that's what we should work towards. Because I'll never take for granted the boring. And I think, I would love for every woman to be able to say that. So, questions? Anything else?